So our last section that I wanted to spend some time with are special populations. And one of the big special populations that I've talked about with some frequency is pregnancy. So with pregnancy, there are some specific recommendations that are available through the ACOG and ASAM, and it very highly prefers using opioid agonist therapy. Okay, so it is considered safer and preferential over things like medically assisted withdrawal. So when we say opioid agonist therapy, we're speaking buprenorphine and methadone. Historically, we would really just use methadone, but more and more of the time we're using buprenorphine instead. Okay. So anyone who's considered a pregnant woman who's physically dependent on opioids should be considered to receive methadone or buprenorphine versus doing something like psychosocial treatment and withdrawal. As I mentioned before, many practitioners will still use buprenorphine without the naloxone, so the Subutex product. But the recommendation is to avoid antagonist therapy. Again, we're trying to avoid significant withdrawal in the fetus as well. And one of the big keys here is all of that wraparound care, right? So care during and after pregnancy and during childbirth. Then this can include things like sexually transmitted infection screening, addressing appropriate pain management during the laboring process, and monitoring and encouraging breastfeeding as appropriate. And part of the reason for the concern is the risk of neonatal abstinence syndrome, or NAS. And this is a general term that's used for withdrawal symptoms following birth, but most commonly applied to opioid use. Now, there are a number of different ways that we can manage neonatal abstinence syndrome. There's some great non-pharmacological interventions that can improve comfort. So things like encouraging breastfeeding, appropriately swaddling, having that close connection with the individual who gave birth. So usually considered the mother, right? So rooming in, education with mother, being present, right? To that comfort of having that familiar body nearby, right? And then we can use medications. So most commonly, morphine and methadone are used as pharmacological interventions to help reduce the symptoms of neonatal abstinence syndrome. If those are not sufficient, we can reach for other products. So things like clonidine and phenobarbital can be utilized in this population to help reduce those effects. Now, it's also important to talk about things like the developing individuals, children and adolescents, right? So the typical recommendation is to start screening for presence of substance use disorder around the age of 11 and focusing on prevention, right? So if we think about some of the risk factors for developing a substance use disorder, early exposure is a big one. Right? Our brains are engaging in higher rates of neuroplasticity and tend to be more susceptible to the neuroplastic influence of substances of abuse. Okay. So education is really important. Judicious use of appropriate pain medication, because there will be times where kiddos and adolescents require, opioid pain medication. So using them appropriately and thoughtfully, but still using them when needed. First line, psychosocial interventions, particularly if they're under the age of 16. So children, there's not a lot of great data, not a lot of good understanding of use of things like medications for opioid use disorder. So it's hard to say what that risk versus benefit truly looks like for that population. And if we're able to utilize non-pharmacological interventions, that's going to be preferred. For individuals that are age 16 and older, we can utilize the same similar products that we've talked about before. So buprenorphine and naltrexone. Methadone is a little bit more tricky because of some of the legal spaces with it and access spaces. So by and large, it would require additional consent for utilization of methadone. Now, a couple other pieces when it comes to our special populations that I think are really important to talk about. So is pain management. So a lot of individuals who have opioid use disorder may have started out using it appropriately for pain conditions, right? Or someone who has opioid use disorder may be undergoing a trauma or a surgical intervention, something that could cause very likely pain. And individuals who have opioid use disorder may have different sensitivities to pain. They may actually have hypersensitivity to pain. And just like anyone else deserves appropriate pain management. Now, we always want to think, and this is true outside of patients who have opioid use disorder, but we always want to think about alternative treatment strategies and what's appropriate for, what's going on with them. So behavioral interventions, biofeedback, physical therapy, absolutely. And then non-opioids, so things like acetaminophen and non-steroidal anti-inflammatory drugs. Can we utilize them? How should we utilize them? Depending on the individual characteristics, as well as, the type of pain, etc. If they have pain and opioid use disorder, we still can treat both together. Sometimes that might mean tapering off of naltrexone prior to a surgical intervention. Sometimes that might mean giving buprenorphine doses on top of their typical doses to help manage pain, and even using full agonists if someone is on using methadone. A lot of times adding an agonist on buprenorphine is not going to be as helpful because of the affinity of buprenorphine for opioid receptors. But if, in particular, if someone's using methadone, giving them a short course as appropriate of opioid pain medications might be appropriate. And of course, shared decision-making is incredibly important here too. Some individuals may be very hesitant and want to try everything possible to not be prescribed additional opioids. Some may be in significant enough pain and feel stable enough in their opioid use disorder to responsibly and insightfully use pain medication based on their situation. So lots of shared decision making here. And the last piece when it comes to special populations that are worth talking about is individuals in the criminal justice system. So if we think about stigma, if we think about some of the influential factors that perpetuate substance use disorder, part of it is social isolation, stigma, lack of feeling safe, having good resources. So oftentimes individuals who are in the criminal justice system are more susceptible to those kinds of things. So when someone is introduced into, the criminal justice, through, getting arrested or being in jail or prison, etc., the recommendation is to include treatment and appropriate treatment. So this should include things like offering as appropriate medications for opioid use disorder. This is obviously going to be individual based, but should be widely available within the criminal justice system. If they're prescribed things like methadone and there's not a treatment center that works with that, jail or prison, etc., then the recommendation is to consider transitioning to buprenorphine. They should be connected with treatment resources after release and be given things like naloxone, so some harm reduction tools and resources, not just within and during their time in the jail system, but also following release from jail, because that is a time where people are going to oftentimes be more susceptible to the effects of opioid use or to the risk of experiencing an overdose on opioids because of that dynamic nature of tolerance. And that's all the new information I have to provide. So I got my little summary slide I'll just go through real quick. So by and large, substance use disorders, not black and white, right? Not everyone presents the same way. Not everyone has the same risk factors, the same kind of prognosis and progress through their illness. But we have a lot of potential interventions that can be really helpful in improving people's quality of life. So things like addressing intoxication, managing withdrawal, and then maintaining their abstinence, or if their goal is to reduce use, maintaining ways to reduce harm through our interventions. So there are a lot of different treatment options that can be considered in patients with things like alcohol and opioid use disorder. There's not as much for things like stimulant use disorder, for example. We do have some options that are available, but from an FDA-approved perspective, opioid and alcohol use disorder do have some supported products through FDA approval that should be considered and offered as appropriate. Harm reduction, absolutely. We want to encourage and use, whenever possible, harm reduction techniques for individuals who have substance use disorders, and always reach out when you can, right? So consistently offering recovery resources in a non-judgmental, non-biased, non-coercive manner, you might just catch them that time, right? Just because they weren't interested the first time we offer those resources doesn't mean that this time they're going to be the same, right? People will at various times in their lives be at a different level of readiness to enact that change. And it's just so meaningful if you're there and you ask them that question and they're ready, right? They're ready. You have what they need. Get them on the right track to feeling better and having the quality of life and happiness and health that they deserve. Thank you so much for listening. Appreciate y'all. And I hope you all take care of yourselves. Thanks.